So that's a great segue. So essentially, this patient that we're talking about, assuming that the scans are negative, and Alec, you brought up the point that we know based upon some of the studies that have been done is that even though they're asymptomatic, but we know that about a third of these patients may actually be harboring undiagnosed metastatic disease. But let's just move that they've gotten scanned, the scans are negative based upon bone scan CT, and so this would be index patient 1 in the AUA guidelines, or this M0 non-metastatic CRPC. So Dan, as we sit here right now, not projecting 3 months from now, but right now, what are the options for that patient?
Yeah, this has been really, I think, one of our unmet needs in the field, because this is a patient that, we're going to sit across the table from and talk to them about their rise in PSA, and we're really not going to have any therapy that's proven to benefit them. Yes, there are anti-androgens that historically we've used, like bicalutamide or flutamide, but they've never shown a clinical benefit in this setting. And so we're modulating PSA, and that's it. There's been studies to look at targeting bone, like with denosumab, that have shown a modest effect in delaying the time to metastasis, but that didn't meet the bar for the FDA. And so we're left with really kind of an unmet need, an opportunity to say, gee, we can look harder for this cancer, but we know that PSA is an indicator that the cancer is waking up from your hormonal therapy. It's castrate-resistant, as Neil has outlined. And there's a few markers that help us decide who's really at risk for developing those early metastases. PSA levels that are over 10 are at higher risk. PSA doubling time, particularly PSA doubling times of 6 months or less, are at particular high risk of developing bone metastasis in the next year or two. So looking at those markers, we kind of know who we can sit and watch for a little while, PSA 0.2, that's maybe going slowly, and who we kind of know in the next year or two is likely to develop metastatic disease that's grossly metastatic. And I kind of cringe at this term of non-metastatic castrate-resistant prostate cancer, because it's a terrible misnomer. We know most of these patients have had their prostate out. There is no primary. We know this is metastatic disease. It's just not radiographic metastatic disease. And we probably need to explain that more. To me, the non-metastatic castrate-resistant clinical trials we'll talk about, they're really low-volume metastatic disease studies. So, yeah, I just want to make that clear, because I think the nomenclature is really misguiding.
Those are great points, and again, I think the audience does really need to understand this, is that those patients, as you appropriately stated, we know that historically, based upon some data, that within a couple years, they're going to flip their scans and they're going to go positive. So that being said, before we start launching into some of the stuff that's just been presented, Alec, when you get those patients, I'm assuming they all get shunted into your advanced prostate center.
Yes.
How does the monitoring scheme change for those patients? Because probably many of them are on every 6-month follow-up, depending upon their shots, every 4 months, but when you start to see this, do your monitoring schemes change? How often are you scanning? What lab work are you getting? Those types of things.
So first, I have a question. So it's probably for Phil. So here I am, Joe, urologist in the community. Fluciclovine became available. I know there's no first level evidence for use in this setting, but yet there's this temptation to use fluciclovine to see if I could in fact identify metastases and then reasonably institute treatment. What is the weakness in that?
So there is no weakness. And if you actually look at the label for fluciclovine, it actually just says elevated PSA following prior therapy. It doesn't say prior definitive therapy. It doesn't say distinguish the different disease states. So you're right. I think that falls under the label. To me, if you're willing to image and act on the results of that imaging, then I see no problem with that. Because as we heard, these patients have metastatic disease. And even though the trials talk about M0, we know they're out there. It's just a matter of what tool you're using. So if this is a way that you can get a patient into that M1 space officially to start treatment, I think there could be value to that, and I think that's an area that we need to look at and figure out. Again, going back to this idea of combination or layering, what are the best ways we treat these patients, and how do we use imaging as a tool?
That being said, we're not doing that routinely, but so we still have a lot, even within our system, there's still a lot of variation in care because the care is systemized in a fashion that the navigator and the system interact with the individual urologist, but there's still a certain amount of variability what the urologist choose to do. So it's a transitional time, but we hope to at least be able to obtain PSA testosterone every 3 months, if not every 6 months. Alkaline phosphatase is often helpful in this setting, and then image based on the radar guidelines.